few recommendations on where we're at now and going in the future.
Yeah, it depends where you're coming from. From what perspective?
From like Joe, a hospital that is trying to push into this electronic correction.
Here's the fundamental analogy for what's happening with hospitals right now. For the most part, they've implemented very large hospital-based systems. For the most part, they tend to be very rigid, very closed environment, very protective of them. So consider it the Rubik's Cube, but the Rubik's Cube doesn't move. It's closed. There is no interchange. A doctor from the outside really can't get access to it. And by the way, to get to the point of 4 hospitals working together, that was a major miracle. So the challenge is, if you're already in an established environment with a legacy system, how do you actually open up some of those interfaces to an open environment, a web-based system, so that you can create the transportability? Don't change everything that you got running in terms of back-end processes at the hospital, but at least open up your interfaces so that the record can move back and forth.
Thank you. Got a question back here.
Yeah, this may seem just very slightly wondering, but I do really have a question here, and that is, some of the lawyers in the group will remember that somebody once said that of a certain area of the law that it was less important that the law be settled correctly on that point than that it simply be settled. And building on what Jose mentioned about the VISTA system, I can remember 30 or 40 years ago when I was in Boston, and Harvard Community Health Plan, for example, had an electronic medical record system. I wonder, in looking at the analogy of the cellular phone development in the U.S. versus cellular phone development in Europe, for example. In Europe, they very quickly standardized the format for cellular phones, and they were able to move ahead very quickly as a result with applications and features. I wonder if it wouldn't be a good idea, rather than have the kind of 100 flowers approach that we have currently to the development of the software in this area, is simply to decide somewhere, CMS or whoever, decide on a system and make that system uniform for the country, and we can, I think, move ahead much more quickly. I've heard, for instance, you didn't talk about these today, but RIOs, the Regional Health Information Organizations, I mean, what a pathetic effort that has been up to this point, largely due to sort of divergences of views. Of course, there's proprietary issues and there's privacy issues and so forth, but a lot of it is just simply, pure, kind of bloody-mindedness about my system versus your system. I mean, really, isn't it time for, as a matter of public policy, for there to be the adoption of a national system in this area that will extend into hospitals, doctors' offices, payers, and let's just get this done.
Yeah, it was started up 4 years ago as a federal effort. Dr. Richard Brailer was brought in to lead the National Health Information Network. After 18 months of it, he actually resigned from the position. The conflicting interests were massive. The infrastructure, the technology was all laid out. Actually, it was a thing of beauty. However, the conflicting elements of it. So we're going to get back to free enterprise will actually drive it. And whoever takes the street sign by street sign or street light by street light approach and actually creates the simplest, most intelligent way to get there will actually get the market share. This is how the PC business evolved. It wasn't a government mandate. It was actually whoever developed the best product, the better mousetrap, actually evolved. So what we're going to see here is the government, the better it stays out of the way, the better it's going to be for everybody. We will participate also in the Government Health and Information Network here in the state of Florida. All the RIOs failed. 3 years after, well, we funded it, and okay, you got two hospitals connected. Now what? Okay, it's a whole lot bigger than that. So whoever has the most patient records in this business actually has the most currency in this industry.
I've been asked to
Just very
wrap
quickly,
up,
not
but I
to
want to
be
let...
argumentative, but the analogy with the PC business, I think, is a good analogy, but not for the reason that you cite. I think it's a good analogy because basically there were, from the very beginning, one operating system. There were many people making equipment for it. There are many people making applications to run on it. But
Okay. Sorry, just as a counterpoint to that, we have the experience of the UK, the national healthcare system, a single-payer socialized system. They have spent to date 12 billion pounds, which is about 25 billion bucks, on a massive nationwide re-engineering electronic healthcare record system. The last I heard, it's not coming along quite as expected, and it's now at the point where a growing number of British citizens are opting out of having their personal health record in a big cloud up in the sky where they don't know who's going to pick into that data. So again, there are points and counterpoints, but we need to look at the UK, where they have gone through this nationwide massive megabuck deployment, and it's been a fiasco. So maybe the answer is in the middle.
Jill, do you have something to add?
Yeah, talking about with FEHIMA and my efforts on the legislative committee right now, we went to Hill Day, about 20 of us that are in the HIM profession from the state of Florida, and we were supporting an electronic record legislation. What it is it's basically a spin-off of the RIOs. It's a legislation to ask the state of Florida to provide low-cost loans to the physicians so that they can afford to start, kind of like the grassroots start at the physician level, but they would have to be interoperable. They'd have to let the systems talk to each other to do these low-cost loans. And the last, I think yesterday was the latest email that I have. It was already passed at the House, and it was like 3 stops from the Senate floor to pass this legislation in order to get the doctors low-cost loans, because they're the ones that it's expensive and they can't afford it more than the hospitals.
Mm-hmm. Yeah, one other point I would like to add to that is that it is true that regardless of what systems are out there, we do need to be able to have those systems communicate with each other. And standardization is key in order to do that. What good is medical records from any organization, hospital, community, clinic, if the other healthcare provider can't even use it? So it has to be standardized. There is some standardization in the industry. Again, going back to the point that I made earlier, we're not developing new technology here, folks. This is not something that has to come out of the skunk works, if you will, to come out to healthcare. It is there. It's been there for decades. There's standardization and information already. It's just a matter of implementing it. We're doing it on our side. There's plenty of opportunity to make it happen. There is bills that are being passed to help the practitioner, if you will, afford these technologies.
Great. I'd like to thank the panelists here. Appreciate your time and effort. And of course, the Quantum Group for sponsoring this. And I think we're going to break for the reception, but do me a favor, we've got a lot of great sponsors around here. Stop by and visit them. I know, let's just buck it out.